Hey guys, good afternoon.
Hey, Dr. Ibrahim.
So today we'll talk about cardiomyopathies. So the reason we talk about cardiomyopathies, there's obviously association between congestive heart failure symptoms, heart failure with preserved ejection fraction, reduced ejection fraction, and cardiomyopathies. Remember that if you're gonna act, if we're not really gonna act according to the standards of care right now, we really don't like systolic and diastolic. We like heart failure preserved and heart failure reduced ejection fraction. Why? Because the pathology is different and the pharmacotherapy is different, right? The rejection fraction less than 50% is reduced, more than 50% preserved. So cardiomyopathies, traditionally, actually, before the era of PCI and restoring flow um, in the cath lab, i.e., before the 90s, um, the number one cardiomyopathy was ischemic cardiomyopathy. So, as you know, if you lose if you lose 20% of 15 to 20% of your cardiac muscle uh, in any kind of heart attack, your ejection fraction is going to be reduced significantly and probably most of the time below 40%. So it really doesn't take much to affect the function of the heart. And when you have ischemic cardiomyopathy, the really the outcome is going to be a little bit different than non-ischemic dilated cardiomyopathy. So ischemic cardiomyopathy, as um, kind of by definition, if you have a blockage in one of the main epicardiac arteries, i.e., RCA, circumflex, or LAD more than 70% is ischemic. I don't think it's really very accurate way to assess, and this is what Medicare wants when we fill in any form for ICD implant. If you have more than 70% is ischemic, but I think it's really a little bit more complicated, more complicated than that. Nevertheless, remember if there's any CAD or stenting, CAD more than 70% major artery or history of stenting or cabbage, ejection fraction is low, is ischemic by definition. All right. Um, Now, the non-ischemic dilated cardiomyopathy in general, non-ischemic dilated cardiomyopathy, it has a better prognosis than ischemic cardiomyopathy. Uh, why? Because in ischemic cardiomyopathy, to have reduced ejection fraction, you should lose part of the heart muscle via silent or acute myocardial infarction or history of myocardial infarction, and the loss of muscle is going to be replaced by scarring, and remodeling by giving medication is not going to be that easy. Also, remodeling by doing devices such as CRTD and stuff like that is not going to be as easy. So the non-ischemic dilated cardiomyopathy is like 50-50, kind of 50% idiopathic and the other 50% related to other factors such as alcohol, cocaine abuse, certain drugs such as cancer treatment, adriamycin, and so forth. Um, the non the idiopathic, we think the idiopathic is related to some sort of viral infection such as Coxsackie virus or adenovirus or stuff like that. There was one study done in 2008. It was actually went all the way to New England Journal of Medicine about antiviral treatment for if you can identify. It really never pan out. So we stuck with the non-ischemic dilated cardiomyopathy, um, uh, that 50% of them that we think related to viral infection. Now, also part of the non-ischemic cardiomyopathy is or dilated cardiomyopathy, is the postpartum cardiomyopathy, which happened uh, the last month of pregnancy and up to 6 months by definition. And this kind of postpartum cardiomyopathy, if patient survives, the outcome is extremely good. So Non-ischemic cardiomyopathy is again, um, uh, you know, you got to be careful about finding out the etiology. So if you think it's related to alcohol, outcome usually is really good if you stop alcohol. If you think it's related to drugs, the cocaine or, that outcome is great. If you think it's related to adriamycin or some of these anthracyclines, the cancer treatment, you have to figure that out early on because most of the time actually is irreversible. So you really need to be very careful. Nowadays, they try to do strain and strain pattern to try to find out if you have any kind of heart function effects from the medications such as adriamycin, anthracyclines, and some of the lymphoma medications or breast cancer medications. Um, because, we think that most of the time, actually, if the damage happens, is not going to be reversible. So you have to be very, very careful. And if you think this patient is taking medications like that, you have to get echocardiogram quite frequently and try to find subtle changes. And you may need to calculate your ejection fraction to find out if there are any even changes between, if somebody has 65% and ejection fraction goes to 58% by Simpson's method of calculating ejection fraction echocardiogram. So you have to report to the physician, and they need to really cut down on the dose or stop the medication completely. So it should have some collaborative, collaboration with the cancer specialist. Now, then you have the restrictive cardiomyopathy, which is the worst part of cardiomyopathies. And the restrictive cardiomyopathy could be related to infiltrative disease such as sarcoid, amyloid, um, uh, uh, history of radiation therapy that can also give the restrictive cardiomyopathy. The outcome is extremely bad, and we really don't like dealing with it. Even though the ejection fraction may be normal, but that doesn't mean the systolic function is normal. And most of the time, these patients live with very high filling pressures, and i.e., heart failure and pulmonary edema and lower extremity edema and ascites and so forth. Nowadays, we really don't deal with a lot with radiation, for instance, radiation-induced cardiomyopathy, because the shielding has become much more effective, and we're very careful about the areas of radiation. But 30 years ago, 25, 30 years ago, some of these radiations were brutal, especially in the cases of esophagus cancers or breast cancers. So when you take history from your patient, you have ejection fraction is normal, left atrium is very dilated, patient may be or may not be in atrial fibrillation. Remember to ask about history and history of radiation, especially if it's old radiation. You have to be very careful. Treatment is really, really bad in that case. And probably you're going to end up only with Lasix with this kind of patients and blood pressure control. Nothing usually affect the natural history of the disease, such as the Entresto or Scubitril, Valsartan, or Arni, whatever, these kind of sophisticated medications, they don't really have much effects. Now, the amyloid, we got a couple types of amyloid. Nowadays, they have kind of start having specific treatment. We don't really have much experience with it. Some of these chemotherapy treatment can make a difference. Granted, if you have a patient with amyloid, the outcome is usually poor. If you have patient with severe heart failure symptoms, wall thickness is increased, you do EKG, you should have a lot of forces. QRS should be large, but if the QRS is not large and you have thickness, that means there's infiltration in the myocardium, and you have to really think about amyloid. And if that's the case, You have to check, the UPEP or SPEP, uh, uh, plasmapheresis, protein electrophoresis in the urine, and protein electrophoresis in the plasma, to find out if there's an indication of amyloid. And again, the outcome is usually bad. So patient comes, ejection fraction is normal, bad heart failure. Actually, we had, me and you, remember that guy in Cathedral? I think he had some type, yeah, but there was really nothing. Yeah, I think he had amyloid, to be honest with you. So your heart is thick. You don't have much QRS on the EKG. Your left atrium is very dilated. It's bad heart failure symptoms. May or may not have atrial fibrillation. You really need to think about amyloid, and the outcome is bad. The outcome is really bad. The other infiltrative disease, which is sarcoidosis, usually African Americans, more common. Um, there is a certain treatment for that, the immunomodulation, azathioprine, and the prednisone and stuff like that. Usually, these kind of patients, they have some conduction abnormalities such as left anterior fascicular block, left posterior fascicular block, right bundle branch block. PR interval is enlarged, or is prolonged. PR's duration is prolonged as well. So these kind of patients, they have usually better outcome, actually, if you treat them. And we're really not very familiar with the sarcoid treatment. Usually pulmonary are more familiar with sarcoid treatment, and remember the association between the lung involvement, the mediastinal lymphadenopathy, African Americans, and African American, actually women, I think, is more common than anyone else. So that's again, that's sarcoidosis. And remember that if you have decreased ejection fraction, so heart failure, reduced ejection fraction, then you're going to start about thinking about your medications, beta blockers, the ARNIs, Cubotril, whatever, Entresto. Then the third line of therapy is going to be spironolactone. This medication is amazing. I really, whoever works with me in the clinic, I really do like this medication a lot. Huge data about it. And then remember the SGLT2 inhibitors such as Farxiga or Jardiance. So you treat similar to any heart failure, reduced ejection fraction. And you have to have a low threshold of sending patients with ejection fraction load less than 35% for AICD treatment. Look always at the QRS. If the QRS duration more than, actually, we need to talk about devices at some point. If the QRS duration more than 120 milliseconds, left bundle branch block, more than 150 milliseconds, right bundle branch block, anything above 130, just let us know. And I think this patient may benefit from synchronization therapy with CRTD or CRTP, pacemaker or defibrillator, doesn't matter, but BIV device may be helpful in these kind of patients. So the other thing, that there's something called non-compaction cardiomyopathy. It's just a new entity. In the fetal life, there are a lot of trabeculae. These trabeculae will get thinner as the fetus becomes a little bit, far in pregnancy, but some of these non-compaction doesn't get compacted. So there's association between this non-compaction cardiomyopathy with sudden heart arrest and heart failure. So if you look at the heart, I'm going to show you what I mean by that. Just for full disclosure, it's very, very rare entity. I have one patient only. So the heart should be like that, right? You see that? So for the non-compaction, the heart is going to have these trabeculae. You see that? Simpson. Is that right? Simpson? Or who's that cartoon? Their heads like that. Yeah. Okay, so that's the called non-compaction cardiomyopathy. Ejection fraction less than 40%. This patient needs an ICD. History of sudden heart arrest, family history of sudden heart arrest, stuff like that. They need an ICD. There's association with heart failure with this, and again, is a really new entity. There's a Takotsubo cardiomyopathy, broken heart syndrome, um, after major traumatic events, psychology, or real trauma. They get this epinephrine surge that stuns the myocardium, and the myocardium will go into heart failure. You get this apical ballooning. So the apex will be akinetic, and then the rest of the heart is functioning okay, but that will have extremely arrhythmogenic effects. In fact, one of my patients still actually comes to see us in the clinic. She came into the hospital, sudden heart arrest. She was having torsades. She was shocked in one day about 52 times. So the ICU attending at Orange Park told me, what should we do? I told them, nothing, just keep shocking her. She's a school teacher. And I was puzzled by the fact she didn't give me that Takotsubo kind of picture. Her echocardiogram was not that much Takotsubo. She told me that actually took 2 days after she was admitted to the hospital. She told me that, well, my husband was driving my daughter to the school, had a major motor vehicle accident. My daughter survived. My husband died. So she got really Takotsubo. We had to do an ICD on her, and she recovered completely as far as heart function. It was like 40%, now it's 60%. So the Takotsubo in general has very good outcome, a very good prognosis, about 90-95% will recover. Is it recurrent to have Takotsubo? Yes, it does recur. So you have to educate them about the fact that that might recur if they really don't take precautions about being stressed in life. But who can prevent stresses in life? I mean, I don't think anyone can. You can try to control your response to stress, but I don't think anyone will be successful in doing that. So but that's Takotsubo cardiomyopathy, and the treatment for that is really to give these similar treatment with HFrEF, Entresto, beta blockers, and be very careful about arrhythmias. If you feel that they need life vest, do life vest on them. But most of the time, if the heart function recovers completely, there's really no indication to do anything else. Most of the time, actually, you can wean. Is probably one of the cardiomyopathies that you can wean off the medications when it comes to the Entresto or Carvedilol. However, most of the time, about 95% of the time, if your patient is a stage C heart failure, then they will continue to be stage C for the rest of their lives. In other words, you need to keep the medications even though the ejection fraction improves. So the stages of heart failure, since we're talking about that, stage A, when you have risk factors, such as hypertension, diabetes, coronary artery disease. Stage B, when you have decreased ejection fraction with no symptoms. Stage C, when you have decreased ejection fraction and symptoms. And stage D. So when you have decreased ejection fraction, you really need to keep your medications, even though your patient ejection fraction improves. Maybe the only one exception is Takotsubo. Short of that, you have to keep these medications all the time, even if your heart function improves. Because they did study before and they said, okay, the ejection fraction improves. Why don't we stop these medications? Actually, ejection fraction went down. So bad remodeling happened after stopping these medications. So always remember that your patient is on Entresto, heart failure, reduced ejection fraction, EF was 30%, and now you do another echo, EF is 50%. Doc, the Entresto is very expensive. Okay, stop it, man. Don't worry about it. Your EF is 50. Don't do that. Don't do that. That's a mistake. So you have to tell them ejection fraction improves because you are taking these kind of medications. Anything else? Oh, shit. Yes. hypertrophic cardiomyopathy is, I'm probably the local expert in hypertrophic cardiomyopathy. So hypertrophic cardiomyopathy is about 50% genes, which is autosomal dominant, 50% is actually sporadic. In other words, somebody, Mr. John, his son Smith, have hypertrophic. Mr. John may not have hypertrophic, or Mr. John may have hypertrophic. So 50% is sporadic, 50% is genes, autosomal dominant, 1 to 400, 1 to 500 prevalence. The mortality is close to 1% per year, so it's not extremely high, right? Does everyone with hypertrophic obstructive cardiomyopathy? Okay, obstruction is about 70% of cardiomyopathies. The hypertrophic part can be in the septum, apex, free wall, anywhere. But if you have hypertrophy, about 70% of them will have obstruction. So remember, hypertrophic cardiomyopathy, if you don't have obstruction, obstructive cardiomyopathy, if you have obstruction, and obstruction, when you have 30 millimeters of mercury increase at rest in your gradient across the aortic valve and across the LVOT. Don't really need to know about these numbers, but what you need to know that not every hypertrophic cardiomyopathy is obstructive. So there are certain criteria for AICD. Not everyone with hypertrophic cardiomyopathy need an ICD. So the indication for ICD in hypertrophic obstructive cardiomyopathy, if you have non-sustained ventricular tachycardia on Holter, if you survive sudden heart arrest, if you have first-degree relative with sudden heart arrest, if you have septum more than 30 millimeter thickness, and if you have ejection fraction less than 50%. And if you have decrease in, which is not very strong, but if you have decrease in blood pressure during exercise test, treadmill exercise test. So there are certain indications for ICD. Not everyone needs an ICD. Why? Because remember, it's 1% per 1% per year likelihood of death. So it's really not very high, right? If you're gonna slam this patient with ICD, you're probably gonna have what, 0.5% risk of complication, or 1% risk of complication without benefit. So you always remember that not every obstruction, not every hypertrophic cardiomyopathy needs an ICD. So if you see history of unexplained syncope as well, so syncope that you think is related to arrhythmia, history of sudden heart arrest, history of first-degree relative sudden heart arrest, 30 millimeters of septum, non-sustained VT, ejection fraction less than 50%, stuff like that, you have to consider an AICD. Short of that, you really do not need to do an ICD. And these patients, they may have symptoms of heart failure from the diastole, that their diastolic function is not normal. Some of them, they have heart failure from the obstruction, so they have difficulties because of the afterload, increase in the afterload because of the obstruction. And remember, the treatment for this kind of patients is really chronotropic incompetence medication, negative chronotrope medications, which are the verapamil, cardizem, beta blockers. Avoid diuresis because they are preload, afterload dependent. Avoid vasodilators because if you're gonna decrease the afterload, you're gonna enhance obstruction. And you have to talk to them about exertion. As you know, moderate exertion is okay, but competitive exercise is not really welcome. But do not ever tell your patient that, hey, you can't exercise. That's a mistake. Don't run marathon. Don't participate in tennis tournaments, stuff like that. But jogging, walking, working, doing some moderate sports, is swimming, modern sports like that. Some sports like that is really okay, but don't say that you cannot exercise. That's really not good. And What else? I think that's it, right? Any questions, guys? I don't know.
I had a question about hokum.
Yes.
Um, is it common for them to have anginal symptoms or exertional symptoms,
Yes.
or
Yes.
okay?
Why? Because they have thick myocardium, right? So the nerves in general are in the endocardium, and the epicardium takes care of the supply of blood vessels. So it's going from epicardium to endocardium, and because of the thickness, not too much going to the endocardium, and they have endocardial ischemia, and that's very common. You're right.